everybody. Thank you so much to Bev and Friends of Medicare Lethbridge for inviting me, and for all of you for coming out here this morning, lured in by brunch and pastries, more so than thinking about healthcare crises. But I hate to have to be the dose of reality on such a nice morning. So I'm going to try to deliver the bad news first, and then to leave some space for some positive things and work that we can do in the future as well. And when considering the title and the themes that I wanted to work on for this talk, I took a look at the population data for Alberta, which we'll discuss a little bit later. It has really critical implications for healthcare delivery. And a couple of different sources, like Statistics Canada, the Government of Alberta, good old Wikipedia, offer different numbers of where exactly we are in terms of women as a percentage of population. Some said 49.6, some said 50.8. But when we include non-binary and gender diverse folks as well, cis men are actually in a slight minority amongst the population of our province. So for the sake of ease today, we're going to say that women are one half of this province. I won't say which half. I like to say we're the more important half. That's okay, just for this morning. And yet we continue to struggle for that 50-50, for equal consideration and equitable treatment. And that's across the board. That's talking from political representation on local councils, in the Ledge, or Parliament Hill, to concerns around pay equity, to the workload at home or in our workplaces, everything in between. But it's especially pernicious in healthcare. And one of the key reasons why is because women intersect with healthcare from multiple positions. And I want to break those down a little bit today about women as sort of three key roles within healthcare. And the first, of course, is as patients. In theory, women make up 50% of patients accessing healthcare, but we're also patients with very specific healthcare needs. Women are also often the primary and primarily unpaid caregivers. They're helping their loved ones and dependents to access healthcare and other public services as well. And finally, women make up the overwhelming majority of healthcare workers in Alberta and nationally as well. So at each of these points, women face different challenges around equity and access. Are those services available when and where we need them? And when we engage with those services and the systems that deliver them, as patients, as caregivers, and as providers, are we receiving treatment that is safe and equal, fair, and inclusive? And I'm sure everyone in the room here this morning has some thoughts on that, and I hope we get to discuss that afterwards. Through a recent national survey, found that 76% of women believe that the health system is not designed to meet their needs. 76%. 74% in this survey said that they weren't taken seriously with their healthcare concerns. 62% chose to delay or skip seeking medical attention or healthcare services due to embarrassment or difficulty in accessing those services. And 35 to 45% had variously experienced delayed treatment or misdiagnosis. So all of those challenges are not unique to Alberta, but they're certainly ones I think that a lot of folks here in the room can relate to. And they're amplified for women of color, for Indigenous women, women who are on low incomes or in precarious employment, unemployment, women who are unhoused, for LGBTQ and Two-Spirit, women and other folks, and especially for women in small communities, rural and remote communities. So I want to map out a bit of what healthcare looks like for Alberta women in the current moment. That's the bad news. And I want to identify those challenges and the barriers. And then so that we can leave with a little bit of hope in our pockets and fire in our hearts, I'd like to propose some solutions and some things that we can work towards. So just to keep myself amused up here, I gave my sections of my talk little titles and subtitles. So I was going to call this one the healthcare landscape in Alberta, or crisis. What crisis? Because as we know, take your pick. There are any number of crises in the healthcare system right now, because there are so many different factors that have combined to produce a perfect storm. Sort of these individual crises in different aspects of the system that make for a massive system-wide fight for survival. And some of that comes from factors that are out of our control here in Alberta, with difficult economic circumstances, which create more urgent healthcare needs for folks. Climate factors create healthcare need. The lingering impacts of the COVID-19 pandemic, which we're still reckoning with. Staffing pressures globally in many of our countries where we might seek to recruit healthcare workers are also experiencing those shortages. There's an increased demand across Canada, but very particular way, an increased demand for healthcare services in Alberta. We have a growing population by design. We have an aging population, and we have a population that has increasingly complex needs. We have an ongoing drugs toxicity epidemic. And amid all of this, a growing rise in anti-science attacks on public health, on the idea of vaccines, rampant disinformation, attacks on gender-affirming care, the erosion of frontline and research funding, what we have seen in the United States, which are the premier agencies for health and science research, all of those cutbacks that they're experiencing there, and the very explicit barriers that are being put up towards funding that contains the words women or gender, will have widespread implications for that healthcare research around the world, and particularly for Canada, because we rely on those agencies. I'm trying to make sure my timer doesn't turn off here, guys, or we'll be in a bad way. So looking at the numbers here in Alberta, and looking at where we are right now, even thinking back to the last 30 years, healthcare has barely had time to recover from one disaster before the next onslaught. All of that change, all of those complexities accumulate over time and make the situation more difficult. So when we look at this globally, nationally, provincially, and our local situations, these are sort of the seas through which women in Alberta must swim to access healthcare for themselves, or to navigate care for a loved one, or to provide care for others and earn a living. And so when we think about healthcare, we were discussing this, myself and Sherry, on the ride from the airport yesterday. I think healthcare is one of those few constants in our lives that from cradle to grave, we need to access healthcare. And so I wanted to kind of walk through these different points where we often would expect that those services are there waiting for us when we need them. Our first point of care is our family doctor or a primary care provider. It might be a nurse practitioner as well. But between 2019 and 2023, the number of doctors in Alberta accepting new patients dropped from just over 1,000 to less than 250. And that number slightly increased last year. It's around 350, 370 in the 2024 numbers. And that's not distributed equally across the province either. There are so many communities where the number is 0. The Alberta Medical Association estimates that between 800,000 and up to 1 million Albertans will be without a family doctor or primary care provider this year. And that's especially, again, rampant within small communities. And then at key points in our lives, like pregnancy, for example, the need for consistent and continuous specialized care is urgent, and it's time limited. You can't wait 9 months on a wait list for pregnancy care. So for some women and in some communities, midwives could offer a wonderful solution for uncomplicated pregnancies. They are very safe, they're very cost effective, they help to take some of the pressures off of our hospitals. But while the number of midwives in Alberta has increased over the last 5 years to about 180 practicing midwives, and that's up 25% from 2020. Yes, that's a win, that's amazing. They provide around 4,500 courses of care over the last year. So from prenatal through to delivery and postpartum, 4,500. At the same time, there are 3,500 already expecting women on the wait list for care. And the Alberta Association of Midwives estimates we would need to have a 20% increase in trained and practicing midwives to each year just to meet that demand and to ensure that there's a provider in the communities that need it most. Most midwifery care in the province is actually concentrated in Edmonton and Calgary, where there's already a plethora of options, or certainly more options than smaller and more remote communities. You might think, okay, well, at least we can always turn to labor and delivery at our local hospital. Oh, I'm reliably informed that Lethbridge has had some challenges with that over the last couple of years, with a dire shortage of OB and GYN specialists. And I heard a little bit of good news that finally some serious efforts at recruitment have started to turn that around here. But for communities like Rimbey, Sundre, Stettler, Sundre has been without obstetrical care in their local hospital since April 2020. Westlock has had disruptions for obstetrical care in their local hospital since January 2023. Three Hills has no obstetrical care available. These are what are called temporary service disruptions, April 2020. So for so many of these communities, and what's been experienced here locally, women and their families needing to drive further and further to ensure that they have that pregnancy care and that a safe place to deliver their babies. And it goes beyond obstetrical care. In 2024, an average of 29 communities faced these temporary service disruptions per AHS. And most of that was ER closures, these sort of rolling closures of days at a time without physicians on site, perhaps without nurses or anesthetists on site as well. So shortages due to just simply not having the cover for when healthcare workers are sick, when they need to take time off, sort of portrayed as though they're all going on vacation and there's nobody there to take up the work. But healthcare workers need to be able to have a work-life balance as well. So among surgical care, these shortages of anesthetists and the diversion of funding and other resources to the Alberta Surgical Initiative has led to delays in accessing surgeries within local hospitals. It's led to longer wait times for cancer surgeries. We've had delays in accessing diagnostics in terms of lab work. We all will remember the chaos surrounding the transition to DynaLife for lab work in 2023. Some more chaos for the transition away from DynaLife when they very nearly went bankrupt and the province got to pay for it. Okay, maybe we have weathered these storms in our life and we're approaching our later years. What about seniors care? Oh, well, seniors care was experiencing a crisis before the pandemic. And few of those very tragic and hard-earned lessons have been implemented even 5 years later. Very basic things that advocates and caregivers and healthcare providers have been calling for actual decades. Things like minimum staffing ratios, legislated minimum hours of direct care within facilities. These are things that are actually moving backwards currently, where those legislative protections have been removed and eroded. And at the same time, we're seeing the number of cases of neglect and abuse within facilities increasing, which tragically shouldn't have to happen. And more families are having to hire paid caregivers to attend to their loved ones within facilities that they are also paying for out of pocket. Wow, okay, what about pharmacare? At least now pharmacare was a win. Pharmacare was a win for some provinces, but Alberta has indefinitely opted out of the National Pharmacare Plan, despite the benefits to health outcomes, despite the cost savings, and despite the fact that, for example, 3 out of 4 Albertans are in favor of universal coverage for contraception in this province. Contraception isn't just about preventing unplanned pregnancies. It also has many medical uses for conditions like PCOS, endometriosis, perimenopause and menopausal care, and all sorts of these across the board. But regardless, this has huge buy-in as a policy amongst Albertans. So Premier Smith responded to that by saying, well, most people have third-party insurance coverage. And if they can't afford that, then they can surely access some of the provincial government programs. So we don't need this, which fails to acknowledge that there are huge gaps between those two options for people, and neither of them actually cover the full cost of prescription drugs, as well as the prescriptions for diabetic care that was also to be covered under the National Pharmacare Plan. And there was a quote from a fellow political scientist, Professor Laurie Williams at Mount Royal, responding to this particular news story last year. And she said, some people think of this as an issue affecting only half of the population, but of course it also affects families. And I know Laurie, I really like her, I get what she's saying here, but why, can we think of any other healthcare issue, any political issue that would affect 50% of the population, and we would shrug it off and say, well, that's only half of Albertans. Oh, but it also affects their husbands or their partners, so let's make it. I think that is very telling in terms of how we consider these issues that affect women primarily. So no pharmacare for us. I wonder how our mental health is doing these days. Just me? Okay. So surely in these difficult times, we at least have access to good mental health care. Unfortunately, we know that women are, around 47% of women are at risk for developing a mental health disorder or needing mental health supports during their lifetime, as compared to about 36% of men. But especially amongst young women, 18 to 35, access to mental health care is getting more and more out of reach. This is in terms of a national study across Canada completed last year. So the demand amongst this age group is skyrocketing, but it's becoming more and more difficult to access that care. It's highly correlated to your income level, of course. It's also much more difficult for racialized women to access, or for newcomers to Alberta as well, to navigate some of those very few and far between public services for mental health care. So overall, when we look at where we are in Alberta, health funding is not even keeping pace with our growing population. It has not caught up to years of high inflation, and it's also being diverted to these private for-profit schemes, repeating failed experiments that we also then have to pay to bail out. And that's where we are and why we can't access healthcare when we need it. But the other side of the coin here is that this unmet need is like water. You can try to contain it, but eventually it overflows. It finds paths elsewhere. So if you can't find a family doctor and you have healthcare needs, you go to the ER. But the ER is understaffed and the wait times are hours and hours long. You get through the ER, there's a shortage of beds. Or you go to your local ER and they have no doctor on staff and you drive further away to a hospital that's even busier. So at each point, the problem gets shifted to another area of the healthcare system until eventually they're all feeling the same strain. I have put my pages in the wrong order. There we go. Thank you. So the other side of the coin here is our healthcare workers, and I'm going to scurry through this one. Part of understanding where these obstacles start is looking at our healthcare workforce, because who's providing this care? As we know, this also means mostly women. So across the healthcare workforce in Alberta, nurses are 90% women, allied healthcare workers are 80% women, healthcare aides within seniors care are 93% women. Family physicians are 50% women. So who's providing care? Who's dealing with a strained system? It's also women. And we know that staffing and workload were under severe strain in many crucial areas of the healthcare system, even prior to the pandemic, and that those conditions have continued to deteriorate. Parkland Institute put together a report just prior to the outbreak of COVID-19. We were conducting surveys between November 2019 and March 2020 of workers within long-term care, asking them about their workload and staffing challenges. So at that time, nearly half of those workers said they didn't have time to complete their required tasks each and every shift, which meant either that care needs for their residents were being unmet, cleaning was not being done, or paperwork was not being done, or they were having to miss breaks, stay late at the end of every shift. 70% of our respondents at that time stayed late after a shift at least once a week. And 90% of our respondents said their facilities experienced short staffing. 45% said that their facility never had adequate staffing levels to provide the level of care they felt their residents deserved. This was in March 2020. We had to close our survey because they didn't have enough staff to answer the questions during the onslaught of the pandemic. So when we look at these different aspects of our healthcare system, this is now what nurses are experiencing. This is what family physicians are experiencing. Our folks in lab are also experiencing these pressures because we have added the mismanagement of the pandemic, political hostility towards public sector workers, organizational musical chairs, anyone? Just in lab, I got tired of writing out how many changes there had been to lab service delivery. So morale is really low, retention is even lower. 48% of newly graduated nurses in Alberta intend to leave the profession before they turn 35. It's a national study from the Canadian Federation of Nurses Unions. 6 in 10 family physicians are looking to either leave the profession or to leave Alberta. And that's more prevalent amongst rural and remote physicians. Burnout rates, according to the Canadian Medical Association, are around 50% of physicians, but that's even higher amongst women physicians and amongst racialized physicians as well, and physicians in small and rural communities. We're also finding that these inequities extend to employment conditions. A report that we're publishing by Parkland Institute next month looked at where different employment inequities were experienced within AHS before it got the Klein Hospital blowing up treatment. And they found that not only were there pay inequities, in a highly, again, remember, like 80 to 90% female workforce, women who are employed under AHS earned less than men. Non-binary people earned less than women. People with a disability earned less than people without a disability. People from visible minority communities earned less than those who were not. And that these conditions, in an already very stressful and emotionally demanding job, further contribute to those feelings of stress and overload. 70% of the respondents to our survey said that their jobs were incredibly stressful. 75% said they were emotionally draining, and 35% reported thinking frequently about leaving their jobs. So this sense of who's taking care of our caretakers, because our healthcare workers are also the caregivers within their families and communities. They're also trying to meet their own mental and physical healthcare needs in this same strained system. So I'm going to get to the fun part, but remember that survey data that I cited at the very, very beginning? The one that cataloged the increasing gaps between women's healthcare needs and the capacity of the system to meet them? 76% says the healthcare system. So here's a fun one. That survey was actually funded by and designed by a company called Maple. And Maple is a for-profit virtual care platform that has repeatedly and blatantly disregarded the Canada Health Act and the essential values and principles of universal health care. But they're proposing the solution to our broken healthcare system. Maple CEO Brett Belchetz was referring to the results of that survey in his press release. He said, "We won't fix women's health care by working around the edges. We need a system that starts earlier, moves faster, and delivers care with empathy, agency, and trust. That's what we're building here at Maple." So not only using the very real and painful experiences of women and their inability to feel heard and respected and treated fairly in accessing care at very vulnerable points of their lives. I'm glad that he got to have an advertisement for his company there. But proposing the idea that for-profit virtual care can be the solution to these problems actually has this backwards, because these platforms are predicated on inequity. They're looking for opportunities to exploit these gaps and failures within our public system, and they help to prioritize those who can pay, those who can access the technology, those who are willing to sacrifice their personal data to be sold onward from these platforms, and those who are desperate. Those who are desperate for any care, regardless of how they obtain it or from where that provider or the ethics of that solution. And that's not what our healthcare system is based on, right? Priority based on need. Stop. So when we look at these for-profit solutions, they rely on actually making the system worse for the majority of people who need it most. So I said we were going to end with some positives before they dragged me off the stage. The positive thing is, from a research standpoint, I don't have to work very hard to dig around to find the solutions. Researchers, advocates, healthcare workers, family members, the patients themselves have spent years thinking about what's the best way to improve our healthcare system and to improve that equitable access. And here's what we know. Putting equity and access and equal treatment front and center by bolstering our public healthcare system. Public healthcare is meant to be universal. When we do it right, it means everyone has access to the same quality of care. To do that, we have to start with our healthcare workforce. We have to care for the people who care for us. We have to meet the current need in terms of staffing numbers and planning for the future. And we have to pay them. It's a hard one, but we have lots of money to send to Sam Raish and his sister to rent out rooms and for private surgery contracts. So we must have money to pay our healthcare workers fairly, create the conditions that allow them to do their jobs. So that means giving them paid sick days, vacation cover, so that we can prevent that burnout cycle. Make sure that they have meaningful mental health care supports that they can access. When we do all of that, we can prevent those ER closures, those bed closures in our community hospitals, and we can have enough hands on deck when people need it. We need to not only encourage, but also fund more Indigenous and Black and non-binary and disabled people into good healthcare jobs. Have people represented within the system and helping to create a system that represents them and their communities and their needs. Not boxing them in on the bottom rung, creating workplaces that are free of discrimination and bias, supporting unpaid caregivers, leaning into the solutions that we know work. So, above all, target the root causes of our healthcare inequities, the preventable pressures on our public healthcare system. And there's two big ones that could remove, I would say, 50% of the pressures on public healthcare. The first one, poverty reduction. Poverty is the single greatest factor in healthcare outcomes. And we are one of the richest jurisdictions in the world. Secondly, public healthcare. Disease prevention, vaccination, managing pandemics and epidemics and healthcare crises as they come up. We know what the solutions are. If we can keep people out of the hospitals with measles, with influenza, with COVID, with preventable conditions, we give our public healthcare workers a fighting chance. So let's all support public health care, support the women who provide it and the women who need it and the women that we love and care for. Thank you so much, everyone.